Margaret Thompson presents with a chief complaint of recent unprotected sexual intercourse with husband, ran out of oral contraceptive pills. She's a 27-year-old African-American female with a past medical history of childhood asthma and generalized motor seizures. She's approximately 2 a month and is stable on topiramate. Family history: mother had an MI at 58 and she's still alive. Father died of prostate cancer at 62. She denies any recent alcohol use, and she's a former smoker, quit 3 years ago. Lives in a rented home with her husband and a full-time graduate law student. Allergies reported is to gabapentin. She is currently up to date on all her vaccines. Her review of symptoms: she's positive for lethargy, not in acute distress, positive for breast tenderness, positive for nausea, and positive for intermittent insomnia. Her vitals are blood pressure 110/72, heart rate is 90, temperature is 36.8 Celsius, 14 for respirations. She's 69 inches tall. She weighs 158 pounds, and her BMI is 23.3. Lab and diagnostics findings: she was negative for chlamydia, negative for HIV, but she had a positive urine HCG test. Her current creatinine clearance is 120. The patient's problem is they want to recommend seizure management during her pregnancy. Evidence of the problem: the patient presented to the clinic with symptoms of pregnancy and was shown to have a positive urine HCG test. The patient suffers from generalized seizures and was currently on topiramate. Since this patient is not already on folic acid supplementation, we need to add her on one to prevent neural tube defects. When assessing epilepsy and pregnancy, we need to think about the risk versus benefit ratio. We want to initiate lamotrigine since it does not show significant harm in pregnancy and since it's first line for generalized motor. The goals for the problem are we want the patient to be seizure-free, increase quality of life, minimize adverse effects, and medication adherence. So we're going to add folic acid, 4 milligrams by mouth daily. And then lamotrigine, we're going to add lamotrigine, and we're going to start with the titration. Week 1 and 2, she's going to have 25 milligrams a day. Week 3 and 4, she's going to have 50 milligrams once a day. Week 5 and beyond, the doctor can increase by 50 milligrams every 1 to 2 weeks, and the usual maintenance dose is 225 milligrams to 375 milligrams in 2 divided doses. Monitoring: with folic acid, we want to monitor for flushing, and then monitoring for lamotrigine, there's possible SJS and 10. So we would need to monitor for efficacy, seizure frequency, and monitor the serum levels of the lamotrigine.